Hello, everyone, and welcome to today's webinar in the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Michael Strife, and I serve as the Medical Director for the Johns Hopkins Anticoagulation Management Service, and I also chair the Medical and Scientific Advisory Board of the National Blood Clot Alliance. I'm especially delighted to be with you here today to moderate today's webinar on the very important public health topic of venous thromboembolism in patients with cancer. Venous thromboembolism, as you know, includes deep vein thrombosis and pulmonary embolism and affects millions of patients worldwide. Cancer patients are disproportionately affected by VTE and constitute as many as 20% of all patients that suffer venous thromboembolism. In addition, VTE is known as the second leading cause of death among cancer patients. Therefore, improving prevention and treatment is essential to improving patient outcomes. Now, before I introduce our guest presenter, I'd like to go over a few points and helpful tips about joining the webinar. Upon joining the webinar, you'll see two audio options. You can opt to listen via the speakers on your computer or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with the phone and access number and the audio pin. All audio will be muted. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area of your toolbar. The presenters will respond to as many questions as time allows. Today's webinar will last approximately 1 hour. Please note that the webinar will be recorded. We will begin today's webinar first with two brief audience polls. First, we're interested in knowing more about you, so please select the response to the poll question now. Which of the following statements best describes you? Healthcare provider, public health professional, person with DVT/PE or family member, community-based organization, or an industry partner. Now let's see if we have any results to look at. So we have a broad array, actually, in every category. We have a lot of healthcare providers, as well as public health professionals, and as well as a number of industry sponsors and community-based organizations, and people with DVT and pulmonary embolism. So it's great to see such a broad group tuning in for the broadcast. And now I'll do a second poll question. Which region of the world are you from? North America, South America, Western Europe, Eastern Europe, or Russia, Asia or Africa, or Australia or New Zealand? And we'll give you a few moments to select your answer, and we'll take a look at those answers, see where people are coming from. And so we again have almost every continent reflected. We have, most of us are tuning in from North America, not surprising, but we have people from South America tuning in, as well as Europe, Eastern Europe and Russia, as well as Asia and Africa. So it's great to have such a broad group of providers, patients, and industry partners tuning in. And so now with those two poll questions, you know where you're coming from and who you are. I'm going to introduce our speaker. It's my pleasure to introduce today's presenter, Dr. Alok Khorana, who really needs no introduction, but I'm going to give him one anyway, a short one. Dr. Khorana is a professor of medicine at the Cleveland Clinic Lerner College of Medicine at the Case Western Reserve University and the Sandra and Stephen Hardis Chair in Oncology Research. He's also the Vice Chair of Clinical Services at the Trousseau Cancer Institute. In addition, he directs the gastrointestinal malignancies program at the Cleveland Clinic. His primary clinical and translational research program focuses on predictive factors and drug development in cancer-associated thrombosis and gastrointestinal cancers. Dr. Khorana, I think, is recognized as one of the world's experts in cancer-associated thrombosis. He's known throughout the world for the Khorana score, which is the only widely validated risk assessment tool for assessing cancer patients' risk for thrombosis. He's published widely in journals such as the New England Journal, Journal of American Medical Association, and Journal of Clinical Oncology. In addition, he has chaired numerous panels on venous thromboembolism in cancer, including with the American Society of Clinical Oncology, as well as the American Society of Hematology and ISTH. In addition, he's a board member with the National Blood Clot Alliance. Without further ado, though, I'd like to turn over the program to Dr. Khorana. Welcome.
Thank you, Dr. Strife, and thank you very much for the kind introduction. Before I start, I also want to thank the Division of Blood Disorders in the CDC and the National Blood Clot Alliance for arranging today's webinar. My talk today, as Dr. Strife mentioned, will focus on the prediction, prevention, and treatment of cancer-associated thrombosis. My disclosures are listed on this slide, and I'll leave them up for a second. So to start off with, I wanted to provide some historical perspective on this association of blood clots with cancer, and that has been known for a really long period of time. There's some controversy about which physician first discovered this association, but probably the one who's historically most connected with this is Armand Trousseau, who was a French physician and professor who lived from 1801 to 1867. And in the 1860s, he delivered a lecture describing his observations that in some patients in whom you see symptoms of what we now call a DVT, you would suspect that there was an underlying cancer. And that quote from that lecture is stated here. In the old days, we could be very declarative about our opinions. And he says that should you, when in doubt as to the nature of an affection of the stomach, when you're hesitating between sort of benign causes or cancer, and you observe a vein become inflamed in the arm or leg, you may dispel your doubt and pronounce in a positive manner that there is cancer. And his name's linked with the syndrome, so-called Trousseau syndrome, in sort of an ironic way, also because not only is he one of the physicians credited with discovering the association, but it's probably one of the few examples in medical history where he's also was a patient himself. And in fact, on New Year's Day in 1867, a few years after he had published his remarks, called his student Peter in and said that I'm lost. The phlebitis that has appeared tonight leaves me no doubt about the nature of my illness. And indeed, he was prescient about that as well and was found to have gastric cancer and died from it just 6 months later. Today, in 2019, there's a huge burden of thromboembolism that is carried by patients who are already suffering from cancer and by providers and healthcare systems that take care of these patients. The rates of venous thromboembolism, which include deep vein thrombosis, pulmonary embolism, and other vein thromboses, range depending on the type of cancer, but can be as high as about 12% a year out from the diagnosis of cancer, particularly in some of these high-risk cancers, such as gastrointestinal, lung, and pancreatic cancer. Although today's talk doesn't extend so much to arterial thromboembolism, I think it's important to recognize that, in fact, cancer patients are at risk not just for venous thromboembolism, but also for arterial thromboembolism. And in this one really well-done study that was published a couple of years ago by Navi and colleagues from New York, found using a national data set that the 6-month incidence of arterial thromboembolism is as high as 4.5% after a first diagnosis of cancer. That includes such serious events, a 2% rate of myocardial infarction and a 3% rate of stroke. And this is almost double what you would observe over double with what you would observe in similarly aged patients who have similar comorbidities but don't happen to have cancer. So having an underlying malignancy increases the risk of both venous thromboembolism and arterial thromboembolism, and both of those in turn lead to consequences that can be devastating to cancer patients. The most devastating consequence of thrombosis, of course, is death. In this analysis on the left, we looked at patients with various types of cancers receiving systemic therapy in the outpatient setting. This was a study led by Gary Lyman, who's currently in Seattle at the Hutch. And what we found in this analysis was asking which patient, the causes of death in cancer patients who were receiving outpatient chemotherapy. We asked physicians to sort of record the causes of death. And what we found was that thrombosis, which includes both venous and arterial events, accounted for nearly 1 in 10 deaths. 9% of deaths were not from cancer, but were from cancer-associated thrombosis. And indeed, the chance of an early death during chemotherapy is almost 7-fold higher in this population. And the chance of dying from VTE in this population is 47-fold higher in the cancer population compared to the non-cancer population. The death or direct mortality, of course, is a strong association. Indirect mortality also, there's a strong association. And then beyond mortality, there are other consequences to cancer patients that can also be very, very troublesome. Cancer patients with venous thromboembolism have a 3-fold increase in all-cause hospitalizations. And when they're in the hospital, the chance that they're going to stay in the hospital is 3 times as long. In terms of days, that's 10 days in the hospital for a cancer patient with a VTE versus only 3 days in the hospital for a cancer patient with a VTE, without a VTE, but with a similar type of cancer and getting similar chemotherapy. And of course, all of this hospitalizations and all the costs of thrombosis lead to higher inpatient costs for cancer patients, outpatient costs for cancer patients, and add up to a substantial increase in total healthcare costs in this population of cancer patients developing venous thromboembolism. Why is thrombosis so prevalent in the cancer population? Even though it's been over 100 years since Trousseau, we still don't have a full explanation. We have lots of partial explanations, and some of those are listed here. It's very clear that cancer cells, which are shown in green at the bottom of the screen, can lead to secretion of factors that can activate the coagulation cascade. Tissue factor, for instance, is present on the surface of many different cancer cells and is also excreted by cancers in tissue factor containing microparticles. And both cell surface TF and tissue factor containing microparticles can activate the coagulation system and lead to thrombosis. In addition to factors directly secreted by the tumors, there's also inflammatory cytokines in the circulation. Stuff we do to cancer patients, including chemotherapy and targeted therapy, can activate platelets. It can activate endothelial cells. It can further lead to inflammatory cytokines. It can activate monocytes. It can lead to platelet aggregation. And all of these things together lead to the increased clinical as well as subclinical prevalence of the hypercoagulable state that is so commonly observed in malignancy. Although we won't get into sort of pathophysiologic mechanisms today, I think it's also important to understand that this is not a phenomenon that's sort of separate from the cancer itself. The reason there's so much hypercoagulability in cancer is that it's important for cancer biology. A clot around a circulating tumor cell may protect the tumor cell from immune mechanisms within the body. And there may be other reasons, such as activation of angiogenesis with a byproduct of activation of coagulation that's also important for tumor biology. In fact, tissue factor expression in tumor cells can occur very early in malignant transformation of pancreas before even invasive pancreas cancer. And the fact that tissue factor is expressed widely across so many different solid tumors and hematologic malignancies suggests that it's important for cancer transformation. And the byproduct of having tissue factor for cancer reasons is that you end up with clotting issues. So big tie-in between cancer biology and the coagulation cascade. So the 3 portions of my talk today, I'll focus on prediction, prevention, and treatment. Let's start with prediction because that's important to get into the prevention portion of this. As many of you already know, there are multiple risk factors that are associated with the risk of venous thromboembolism in cancer patients. The most important category of factors is cancer-related. I alluded earlier to the type of cancer. Anybody who's taken care of cancer patients knows that there are some types of cancers, such as pancreatic cancer, primary brain tumors, gastric cancers, that are very strongly associated with the risk of VTE. Histology, so the adenocarcinomas, for instance, will have a higher rate than squamous cell cancers. The grade of cancer, in the initial period after diagnosis, are phases when right after diagnosis when patients are most at risk for developing thrombotic events. There are also treatment-related factors, things we do to cancer patients, major abdominal or pelvic surgery, hospitalization for medical illness, treatments we give for cancer, including chemotherapy, but also including many of the newer targeted agents, can lead to an increased risk of both venous and arterial thromboembolism. Placing catheters in, and even supportive care measures such as blood transfusions can increase the risk. There are, of course, certainly patient-related factors. They're not quite as important in the cancer setting as in the non-cancer setting, but older patients are more likely to get clots. African American patients in the United States are more likely to get clots, and patients with substantial comorbidities. So if you also have renal dysfunction, for instance, or if you have pulmonary disease, that increases your risk on top of the risk from having cancer. And then finally, there's a lot of efforts underway to find a biomarker that would be predictive of cancer-associated thrombosis. Some biomarkers have strongly been linked, including components of the blood count, such as platelet counts or leukocyte counts before starting treatment. Tissue factor can be found in the circulation and seems to be associated with thrombosis, at least in pancreatic cancer patients. And there's a lot of data to support D-dimer, which is elevated in cancer patients, but high levels of D-dimer may be predictive as well. Because there are so many risk factors, it's difficult to identify sort of one single characteristic that predicts for high risk. About a decade ago, based on National Cancer Institute funding, my colleagues and I developed a score that Dr. Strife just introduced, where we are able to identify patients who are at high risk for developing venous thromboembolism based on clinical and some basic laboratory characteristics before they start their chemotherapy. Although there are multiple risk factors, we focused on the 5 most important ones, and we found that the type of cancer with very high risk being defined as a stomach or pancreas cancer, and high risk being defined as lung, lymphoma, GYN cancers, and bladder and kidney cancers would get a score of 1. Patients with a high platelet count, a low hemoglobin, a high leukocyte count, or a high body mass index of more than 35 kilograms per meter square each get a score of 1. In our original publication, we categorized the population into 3 categories. Low-risk patients who have a score of 0 had a less than 1% rate of VTE. Intermediate risk patients which had a score of 1 or 2 had a rate of roughly 2%. And high-risk patients were defined as a score of 3 or higher, and the symptomatic rate in this population was about 7% within 2.5 months of starting treatment. Multiple subsequent studies have gone on to evaluate this risk score and validate it. Some selected studies are shown on the left. All told, studies have included at this point over 40,000 patients. But one thing that's emerged from all of these different validation studies is that, as shown on the right, that the score is certainly helpful in categorizing, but even in the intermediate risk population, so a score of 1 or 2, score of 2 patients have a higher rate than score of 1. This was first shown in this Vienna validation study on the left, where patients with a score of 2 or higher had a symptomatic VTE rate of roughly 10% at 6 months. And this was confirmed recently in a large meta-analysis of close to 28,000 patients with 6-month follow-up, where a score of 2 or higher was associated with a VTE incidence of roughly 9%, so very similar to the 10% number in the original Vienna study. Based on this, there's been an evolution in sort of determining high risk, and the consensus now is that perhaps we should consider a score of 2 or higher as high risk rather than just a score of 3 or higher. In addition to that modification, there have been multiple new risk assessment tools that have been developed. I won't go into details of these, but in general, the effort here is to improve the positive predictive value, which means if you define a patient as high risk, can we find patients that are higher than a 10% risk if we go by the score of 2? So can we find people with a 20 or 30 or 40% risk of VTE? And there's been variable success across these different scores. And some of these are still in the validation phase, but certainly much more to come in this arena in the near future. Another point to mention in terms of prediction is that the risk for VTE in a cancer patient is not static, but is dynamic and varies over time. The risk is high when patients are first diagnosed, as shown on the left. It's spikes when acute events happen, as shown in the middle when there's hospitalization or surgery. It probably reduces to almost the normal population when patients go into remission. And if the cancer were to come back, then the rising tumor burden is again associated with the rising risk of VTE, perhaps even greater than the initial diagnosis. And we now know that thromboprophylaxis in this late period can diminish the effect. What are current applications of risk assessments? I've gone through sort of the different risk factors and risk tools that are available in this setting. And today at bedside, there are multiple clinical applications of these risk assessment tools. Number one is education. I'm really happy to hear that there's a lot of patient advocacy organizations and patients and families on the call. When we surveyed patients a few years ago, cancer patients had a very high awareness of other side effects of chemotherapy, such as hair loss, nausea, and vomiting, but had less than half of patients had awareness that they were also at risk of a DVT or PE and did not know the warning signs and symptoms of DVT or PE, such as leg swelling or sudden onset of chest pain. One strategy that was tried in Canada was to introduce the risk score into an electronic medical record, and patients who were a score of 2 or higher were delivered extra educational material regarding this risk, and this increased their awareness and led to early reporting of symptoms. So if you use the risk tool for nothing else, I think it should at least be used to make more educational efforts for cancer patients. The second potential application is screening. In some trials that sort of I'll discuss further down, we've shown that in high-risk patients, especially in patients with a score of 3 or higher, doing lower extremity ultrasound before patients start on chemotherapy identifies about a 10% rate of VTE. That is at the point not symptomatic, but can become symptomatic in the future. And this screening approach may identify high-risk patients, but also prevent them from developing clinical DVT by diagnosing them with a clot that already exists and leading to early treatment, which in turn can prevent hospital admissions and emergency room visits. Probably the most important application, of course, would be prophylaxis or primary prevention approach, which I'll get into in the next section. And just as VTE is linked with mortality, VTE risk scores are also linked with prognosis and can predict, in fact, for cancer progression and mortality. Here's an example of the education approach that was pioneered at the Ottawa Regional Cancer Center in Canada, where all new cancer patients are assessed with the electronic alert. 25% of these patients were found to be high risk and were given educational material, and of them 11% went on to develop a VTE, and hopefully they were able to recognize this warning signs and symptoms because they had received education around this. This is an example of doing ultrasounds in cancer patients. When you target patients with a score of 3 or higher, as you can see, there's about a 9% rate at baseline before patients start on treatment. When you target patients with a score of 2 or higher, then the rate is around 4.5% at baseline before they go on to receive chemotherapy. At the Cleveland Clinic, where I practice, we've been able to use this information to target ultrasound towards those patients at high risk. An electronic alert pops up in the system that identifies patients at high risk for DVT. Screening ultrasound is recommended, and if this is done, we find that about 12.5% of patients are diagnosed with a DVT. If we don't do the ultrasound, we find that about 8% of patients are still diagnosed with a DVT, but that diagnosis is made in the emergency room or in the hospital. And by screening, therefore, the hope would be that we can avoid hospital admissions for these patients. So those are all the ways risk prediction can be used to understand the risk of VT in cancer patients, and hopefully also lead to early, better education and early detection of this diagnosis. Let's move on now to prevention. Prevention in cancer of VTE can occur in 3 major settings. One is after cancer surgery. This is probably the best recognized setting, and it's been known for over 3 or 4 decades now. And the multiple trials listed here show that VTE can be prevented in cancer surgical patients in the immediate period following surgery, and also for an extended period of up to 4 weeks after certain high-risk abdominal and pelvic operations. A second setting is hospitalization for acute medical illness. And a third setting, which has really been the focus of multiple large clinical trials recently, and especially this year, is outpatient chemotherapy. The reason this third setting is most important is because currently, because of advances in cancer medicine, most cancer patients receive their treatment in the outpatient setting, and so 80% of blood clots occur in the cancer outpatient setting and not in the inpatient setting. And so from a public health perspective, if we are to employ prevention approaches, they're probably most useful in the outpatient setting. In terms of hospitalized cancer patients, the data are inferred from studies of acutely ill medical patients that are listed here in the 3 large trials, MEDINOX, PREVENT, and ARTEMIS. But it's important to note that the evidence base for utilizing this in these data in cancer patients is quite limited. Cancer patients only accounted for 5 to 15% across these 3 studies, and the subgroup analyses of these trials were not significant, and we don't have safety data in the hospitalized cancer population as well. So there's a lot of work that needs to be done there. I mentioned risk prediction earlier, and another Canadian multi-center study showed that risk prediction that is used in the outpatient setting can also predict for risk in the inpatient setting. And high-risk patients in this study were seen to derive a greater benefit from thromboprophylaxis, as shown in these 2 bars on the right, than patients with low or intermediate risk. And so really, there's a need to better understand the risk status and benefit from inpatient prophylaxis in this population. Currently, the most widely used approach in the inpatient setting is standard dose enoxaparin or low molecular weight heparin. But we showed in a recent trial that that was co-led by myself and Jeffrey Zwicker from Beth Israel in Boston, that in high-risk hospitalized patients, the cumulative incidence of VTE with fixed-dose enoxaparin, which is a standard approach, was as high as 22% based on screening at day 14. We attempted a better way of doing this, which is weight-adjusted enoxaparin. So thinking here being that cancer patients that are in the hospital have a much higher risk of clotting than non-cancer patients in the hospital, and therefore require a weight-adjusted dose rather than a standard dose. And we hope that we'll get funding to expand this to a large phase 3 randomized trial to evaluate the superiority of the weight-adjusted dose compared to the fixed dose. But currently, there's no randomized data in the hospitalized cancer population. Moving on to cancer outpatients, in the 2000s, there have been large outpatient thromboprophylaxis studies. The 2 largest are shown here, PROTECT and SAVE-ONCO. And between them, they had over close to 5,000 patients enrolled. And although they met their primary endpoint in terms of showing statistically significant reduced rates of VTE in the cancer population compared to placebo, there were a couple problems with the study. Biggest, of course, was that these patients were not selected based on risk, and so it was a variety of different types of cancer patients, but not identified by risk of VTE. And so the event rates in this population were low. In the placebo arm, in PROTECT, including venous and arterial thromboembolism, it was about 4%. In SAVE-ONCO, it was less, 3.5% with just VTE. And the drug dropped those rates, but the number needed to treat, which is a way of understanding sort of public health benefits to cancer patients with primary prevention, was quite high. It was in the 50 range. And so even though these studies were published in high-impact journals and were discussed a lot, they did not lead to guideline changes because they did not show a substantial benefit for cancer patients because the absolute risk reduction was so small. We and others have long maintained that using risk assessment is a better way to identify and to identify patients who would be at benefit from prophylaxis. If you apply the risk score that I discussed earlier to cancer patients in the same one of these studies, the PROTECT study, you can see how the number needed to treat changes. So for the full population, the rates were 3.9% down to 2%. If you focus just on the high-risk population, score of 3 or higher, the number needed to treat is much lower, 15, because the rates are much higher, 11%, and the absolute benefit is 7%, which is also higher, so 11% down to 4%. The number needed to treat drops from 50 to 15. Similar results have been observed across a variety of other studies, all suggesting that at least for patients with a score of 3 or higher, outpatient thromboprophylaxis will lead to substantial benefits in terms of clot reduction without a substantial increase in the risk of the known side effects of blood thinners, which is bleeding. However, these findings have not did not at the time transform into substantial clinical guidelines recommendations, Again, because these were not sort of prospective studies, but rather post hoc analyses or defined subgroup analyses of previously conducted clinical trials. 2019 has been a banner year in terms of primary prevention in this setting. There were two large clinical trials that were published in the same issue of the New England in February of 2019. One that I had the honor of co-leading, CASSINI, which used rivaroxaban for thromboprophylaxis, and the second, AVERT, led by Mark Carrier in Canada. This was largely a Canadian study, using apixaban to prevent VTE in patients with cancer. Let me walk you through the results of these two trials. The study design for both of these studies was quite similar. In AVERT, it used patients with a newly diagnosed cancer or progression with a previously diagnosed cancer and starting a new treatment regimen. And these were both risk-adapted studies, so they used in this two studies as an entry point a Khorana score of 2 or higher. In AVERT, about 570 patients were randomized to either apixaban 2.5 milligrams twice daily or placebo for a period of 6 months, and the primary outcome was the first episode of VTE. CASSINI, as I mentioned, was similar: solid tumors or lymphomas starting a new treatment regimen, also with a score of 2 or higher, randomized to rivaroxaban, except with a 10 milligram once a day dose compared to placebo. The major difference with CASSINI was that there was a randomization after a negative baseline ultrasound. So we took the approach of our prior studies showing that baseline ultrasounds detect patients who already have a blood clot, and so that's not sort of truly prevention. And so we wanted to ensure that we identified these patients with a baseline ultrasound and did not randomize them, but rather treated them for pre-existing DVT or PE. And we also had ultrasounds while patients were on study to standardize sort of screening processes in this population. AVERT showed a substantial and significant reduction in VTE. There were 28 events in the placebo arm, down to 12 events in the apixaban arm. So that's a 10% rate of VTE, down to 4%. This is almost exactly what was predicted by the risk score for a score of 2 or higher, a 10% rate over 6 months. Hazard ratio is 0.4. PE rates were also substantially reduced, 5.8% down to 1.7%. So this shows that prophylaxis, led to a 2/3 reduction in PE. So those are really clinically meaningful events that we are preventing with primary prevention. In CASSINI, the results are a little bit more complicated to understand. Because of the introduction of the baseline ultrasound, we did not see a separation of curves in the initial phase of the study, because I think we had already picked out patients who were about to form blood clots. And so that reduced the power of the study to identify significant differences in VTE between the placebo arm and the rivaroxaban arm. In addition, about 38% of patient events occurred in patients after they had stopped taking the drug. We had pre-specified an on-treatment analysis, which better helps us understand this. And if you look at events occurring in patients receiving rivaroxaban while they're on the drug, event rates are more substantially reduced from 6.5% down to 2.6%. Number needed to treat for the full 180-day period is 35, which is an improvement from 50, and for the on-treatment period is 26. These primary analyses don't take into account other benefits to cancer patients. We also saw a reduction in arterial events, visceral events, and screen-detected distal DVT. And taking all of these into account, which we recently presented at an ISTH meeting, the benefit is even more, 9% down to 3%, and the number needed to treat drops further to 17 for this analysis of CASSINI. There's also a pre-specified analysis of combining the primary endpoint with the secondary efficacy endpoint of mortality, and this analysis also showed a substantial absolute risk reduction, 29.5% down to 23.1% with rivaroxaban. The flip side of any primary prevention approach is, of course, safety, and major bleeding is known to be increased with blood thinners. In the AVERT study on treatment, major bleeding rates increased by about 1% absolute increase, which is a number needed to harm of about 100. And in CASSINI, also absolute major bleeding risk increased by about 1%, which is also a number needed to harm of about 100. Clinically relevant non-major bleeding also increased slightly, but number needed to harm there is even higher at 135. So based on the full sort of preponderance of this evidence, multiple new guidelines have come out and they've all changed what they used to recommend. ASCO guidelines published just recently in the JCO state that high-risk patients with a score of 2 or higher may be offered prophylaxis with apixaban, rivaroxaban, or low molecular weight heparin based on the older data, provided there's no concern for bleeding. The ISTH guidance statement also suggests the use of DOACs as primary thromboprophylaxis. And ITAC, which was just published in Lancet Oncology, also recommends either in pancreatic cancer or in patients who are at intermediate to high risk, that is with a score of 2 or higher, receive primary prophylaxis with direct oral anticoagulant. As I said, it's been a banner year for primary prevention with the publication of these two trials, lots of data post-publication as well, and now with guidelines changes for the first time recommending primary prevention with a direct oral agent. I'll now move on to the last section of my talk, which is around treatment, and then hopefully we'll have time for questions afterwards. Treatment also has changed in recent years. Between 2003 and 2018, the standard of care for treatment of cancer-associated thrombosis, so these are cancer patients with a new diagnosis of VTE, was low molecular weight heparin based on the panel on the left, which is from the CLOT clinical trial led by Lee and colleagues. In this study, they showed that cancer patients, once with a new diagnosis of venous thromboembolism, if they're treated with dalteparin or with an oral anticoagulant, in this setting, mostly warfarin, there's a substantial absolute risk reduction from 17% down to 9% with the low molecular weight heparin. The number needed to treat to prevent one recurrent VTE is 13, and based on this trial, this became sort of the standard of care. A confirmatory trial was done about 12 years later, or published about 12 years later, also led by Professor Lee in JAMA in 2015. And here they found a less substantial reduction, 10.5% down to 7%, the number needed to treat of about 30. And so that sort of casts some skepticism around whether low molecular weight heparin monotherapy should be the standard of care. Around the same time, real-world data was coming out indicating that cancer patients, for a variety of reasons, are not adherent to low molecular weight heparins as they are to oral agents, including to warfarin, which is also a challenging oral agent to use. In this analysis of close to 53,000 United States cancer patients that we published a couple of years ago, we found that of every 100 patients that started on low molecular weight heparin, at 3 months, only 30 of those 100 remained on it. And at 6 months, only 13% remained on it. Numbers for oral anticoagulation, including warfarin, were higher. A third set of data that just came out, sort of again challenging this paradigm of low molecular weight heparin monotherapy, was randomized trials of direct oral agents. I've already talked about direct oral agents for primary prevention, but for secondary prevention, there have been also large randomized trials that have been published. SELECT-D was the smaller of the two trials and used dalteparin, which was the control arm, and showed that if you took a cancer patient diagnosed with a new venous thromboembolism and randomized them to either a direct oral agent, rivaroxaban in the SELECT-D trial, or edoxaban in the Hospitalized trial, recurrent VT rates were actually reduced compared to dalteparin. This is not something I was expecting. I was expecting that there would be sort of similar results. In SELECT-D, the absolute risk reduction was 11% down to 4%. In Hospitalized VTE with edoxaban, it was 11.3% down to 8%. Note that this was accompanied by the known side effect of bleeding, which if you have a better anticoagulant, it's great that you reduce recurrent VTE, but raises concerns that you would increase major bleeding as well. The SELECT-D trial, major bleeding rates were increased from 4% to 6%, and similarly in Hospitalized VTE, 4% up to 6.9%, and that p-value was significant. So these trials suggested that direct oral agents could be used, but the bleeding issue was something that needed to be better understood. Probably the clearest understanding of this comes from a subgroup analysis, the Hospitalized VTE trial, looking at patients divided by whether they had a GI, a gastrointestinal cancer, or not. For patients with gastrointestinal cancer, there was a clear and substantial increased rate of major bleeding. But if you looked at non-gastrointestinal cancer patients, which frankly are the majority of cancer patients because it's everybody else but GI cancers. It includes all the breast cancer patients and the lung cancer patients, and so prostate cancer and so on down the line. There's actually no excess major bleeding with edoxaban in this study. So based on these findings, I think we have a better understanding of how to select patients for VTE treatment with a direct oral agent. It's important to note that many anticoagulants have interactions, drug-drug interactions, with particularly for oral agents with the CYP3A4 and the PGP pathways. And so we have to be mindful that many drugs can be inducers and inhibitors of the CYP3A4 and the PGP pathways, and inhibitors in particular may increase the risk of bleeding with direct oral agents. There's a partial listing here, but really there's so many cancer drugs out there that when you prescribe these drugs, it's important to make sure that there's no known drug-drug interactions. It's easiest if there's an electronic medical record because that hopefully can calculate drug-drug interactions on its own. Guidelines for treatment of cancer-associated thrombosis have also changed recently. The ISTH guidance statement states that cancer patients with low risk of bleeding be suggested no direct oral agents, either edoxaban or rivaroxaban, although low molecular weight heparin remains an acceptable alternative. And for patients at a high risk of bleeding, low molecular weight heparin be considered, high risk being defined as patients with a luminal GI cancer with an intact primary, or patients with active GI mucosal abnormalities such as ulcers, gastritis, esophagitis, or colitis. NOACs are acceptable alternative if there's no drug-drug interactions. ASCO and ITAC guidelines have also changed their recommendations. For ASCO, the initial anticoagulation now includes rivaroxaban in addition to low molecular weight heparins. And for long-term anticoagulation, it includes both edoxaban and rivaroxaban. There's a difference in these recommendations because edoxaban, the way it's administered, is given for a few days overlapping with a low molecular weight heparin and then transitioning to. So it's not included in the initial anticoagulation, but really is meant to be included in sort of the 6-month treatment of VTE. The ITAC guidelines shown on the right, again, prefer low molecular weight heparins over vitamin K antagonists and recommend direct oral anticoagulants for patients with cancer when the creatinine clearance is more than 30 and there's no drug-drug interaction. They also point out that there should be caution in patients with GI tract malignancies. My own personal algorithm is based on this Canadian algorithm, which is that the first question you ask with a new diagnosis of DVT or PE in a cancer patient is, does this patient have drug-drug interactions with DOACs, and are they at a high risk of bleeding? If the answer is no, which it should be for the majority of patients, then we recommend initial treatment with a DOAC. And at 6 months, we ask sort of the same question and make a determination whether anticoagulation needs to continue beyond 6 months. We continue it if the cancer is still active or if they're still on active anti-cancer treatment, such as chemotherapy. If the answer to the question is yes, there's a drug-drug interaction or the patient's at high risk of bleeding, then we would initiate anticoagulation with a low molecular weight heparin as opposed to a direct oral agent. So to summarize, cancer-associated thrombosis is a big clinical problem. It confers an unacceptably high burden on patients with cancer, and these are patients who are already suffering from cancer and the consequences of cancer and cancer treatments. And this adds to that by worsening outcomes, increasing the risk of hospitalization, and especially distressingly, increasing the risk of mortality. The good news is we have made progress. Our risk prediction approaches have improved. Candidate biomarkers are currently being vetted in large-scale studies, and we've moved into an era of better treatment options for patients with cancer-associated thrombosis with direct oral agents. It's important to emphasize, with careful patient selection and individualizing patient treatment based on individual patient risk and benefit, taking into account risk of GI bleeding and taking into account drug-drug interactions. For primary prevention, there appears to be a new paradigm based on findings of CASSINI and AVERT, which have demonstrated benefit to patients with direct oral agents. And with the arrival very recently of new guidelines incorporating these data, they now recommend primary prevention for high risk, not for all patients, but for high risk cancer patients. Thank you very much for your attention. I'll hand this back to Dr. Strife, and I think we can move into a Q&A phase. Thank you.
Thank you very much, Alok. That was a tremendous presentation. Just covered, I think, all aspects of both prevention and treatment. And not surprisingly, we've had a lot of audience questions, so I'll start with some of those. One of the early questions was that given that cancer patients are at such high risk for venous thromboembolism, do you have an approach to handling the perioperative or peri-procedural period differently than you would a patient that does not have cancer?
I would say yes, and you know, Mike, you run the anticoagulant program at Hopkins, so you can chime in as well. But
Yeah.
I think for patients who are at high risk undergoing abdominal or pelvic cancer surgery, we tend to extend the period of anticoagulation to 4 weeks. So we don't stop just with in-hospital prophylaxis, but we continue extended prophylaxis for up to 4 weeks, and that's based on good randomized clinical trial evidence from actually 3 different randomized trials at this point.
Yeah, we're the same for prophylaxis. We often, and our surgeons are all tuned into this for using extended prophylaxis in high-risk cancer patients. And then for perioperative management of anticoagulation, we're more careful about using, we use bridging when it's, just because particularly if it's an early on in the treatment phase, use bridging where you wouldn't necessarily use that for patients without cancer.
Yeah, I have the same approach.
Another question is, do you have a minimum platelet count where you consider these therapies appropriate, anticoagulation appropriate that you use?
Yeah, that's a great question. I'll guide you to sort of 2 papers. They're both by Bethany Samuelson. One's a systematic review of sort of different studies that have looked at platelet counts and use of anticoagulation, and one's an ISTH guidance statement. Both of those essentially say that up to a platelet count of 50,000, it's safe to continue anticoagulation at sort of your regular doses, because patients, even with thrombocytopenia, continue to be at risk of thrombosis. So, the hypercoagulable state is so dominant in cancer patients that it doesn't get better just with lower platelet counts. Less than 50,000, there's not a lot of randomized data because those patients were not included in randomized clinical trials. There's some data to suggest that you can continue at least half dose between 30,000 and 50,000. And then below a platelet count of 30,000, my practice is to stop anticoagulation because at that point, you're really worried about the risk of bleeding.
Alok, there are a lot of questions about apixaban and the ATOM data that has just come out. What are your feelings about the ATOM trial and Eliquis or apixaban for treatment of DVT, PE? Cancer?
Yeah, so the ATOM trial was I think it was designed as sort of a pilot feasibility trial, so it's not a definitive randomized trial, and it did not meet its primary endpoint because there were so few major bleeding events in both arms. So this was to sort of, for people who don't know what ATOM VTE was, it's a randomized trial of cancer patients with an acute diagnosis of VTE randomized to apixaban versus low molecular weight heparin. There were almost no bleeding events in the apixaban arm, and then there were only 3% bleeding events in the low molecular weight heparin arm. Those are both much, much lower, and both arms are much, much lower than what we've seen in the larger randomized trials. So the data are encouraging, but please be aware that there's a very large randomized trial using apixaban that has completed accrual. It's called Caravaggio. It's a worldwide trial. It's more of a definitive randomized trial of the kinds that we are used to. And hopefully we'll have results from that soon, and that'll provide us more information about the use of apixaban.
Terrific. I agree completely. And there was also interest in an area you weren't able to get into about the use of anticoagulation to modify the natural history of cancer with prophylactic dosing of anticoagulants.
Yeah, that's been, I didn't get into it because there's not a lot of new.
Sorry.
Yeah, so that's a subject that's, as you know, Mike, it's been around since the 1990s. In fact, I spent 2 years in the lab right out of training looking at heparins and how they can modify sort of angiogenesis parameters as other people have. And the initial data seem to suggest that anticoagulant approaches can alter the natural history of cancer and potentially increase survival rates. But when definitive randomized trials were done asking that very specific question, they have not been able to demonstrate such a benefit. So there may be a benefit, and maybe we need better design studies to show that. But there's been a slew of negative randomized trials, and so I certainly don't think that that's a reason to prescribe anticoagulation. And in fact, the ASCO guidelines specifically recommend against that. For direct oral agents, that data has not been studied at all. That question has not been studied at all. In CASSINI, we saw numerically lower mortality rates, as I showed. In AVERT, there was no impact on mortality at all, and numerically the rates were higher with the apixaban arm. So I think between those two trials, we don't have any consistent data.
Alok, since you're using screening in your patients that have high Khorana scores, do you treat all the clots you see, even if they're distal, in cancer patients?
We do. There's good evidence, and we actually have a paper in, I think it's in press now, looking at distal events in cancer patients, and the rate of recurrent VTE with a distal DVT is almost the same as with a proximal DVT. So I think once you start getting any clotting events in cancer patients, as you know, it's not a transient hypercoagulable state. It's a really persistent, very dominant hypercoagulable state. It's not like a knee replacement or hip replacement where you find a clot and most of those sort of melt away on their own. And so in that setting, I don't believe that screen detected clots are the same. But in the cancer setting, whenever we've done screen detected clots, as we often find them on CT imaging, for instance, for cancer purposes,
right?
They seem to behave just the way a symptomatic clot would.
Right.
So we tend to take them pretty seriously, and we anticoagulate all of those events.
Alok, when you're evaluating someone for primary prophylaxis, a cancer patient getting ready to start a new regimen, do you use any bleeding risk assessment at all in formulating your plan?
No, that's a huge gap in the field. We don't have. I think we've spent a lot of time sort of trying to understand the thrombotic risk, but we have not had as formal an approach to understanding the bleeding risk. I think the most obvious way is to acknowledge that GI cancer patients bleed the most. I think that's very clear across all the DOAC studies. Even in the prophylaxis studies, most of the bleeding, not all of it, but a lot of it has been GI associated.
Mm-hmm.
So I tend not to use these drugs in patients with esophageal and gastric cancers where the esophageal or gastric primary is in place. I think those are the patients most at risk. If you look at pancreatic cancer patients, for instance, they're classified as gastric, but the tumor typically does not invade into the lumen, and so those patients don't really tend to bleed. So I wouldn't sort of categorize all GI cancers in one bucket as being at high risk, but I think depending on the type of GI cancer and then depending on whether there's luminal involvement or not, I think you can select out some patients who are clearly at high risk for bleeding.
Are there any data regarding use of mechanical prophylaxis in cancer patients?
There is in the post-operative setting, but not in recent years. And I think those are all data from the 90s and the early 2000s. In the gynecologic oncology literature, so in patients with ovarian cancer and uterine cancer, there's some data that suggests that combining mechanical with pharmacologic prophylaxis is better than pharmacologic prophylaxis by itself, but they're not very compelling data. Certainly, we would use it in patients who are at risk of bleeding, and you can't use, an anticoagulant. Do you agree with that, Mike? Or do you?
No. I think that if you can't use in the surgical population, there's a lot more data. In the medical population, there's an ICU study that came out that really didn't show that the mechanical prophylaxis added anything to pharmacological prophylaxis. So but specifically in cancer patients, it's just not a lot of data. So, yeah. And along the same vein, there was a question about warfarin in primary prevention. I don't know of any data, but have you heard about use of warfarin in that regard?
No, there was one study back in like 91 or 92 run by Mark Levine in breast cancer patients that showed benefit from warfarin. But this is 27 years later, and breast cancer treatments have changed, prognosis has changed. That was back in sort of the tamoxifen days, I think. And even that study was driven by a very few number of events. So certainly warfarin is not recommended in any primary prevention setting. I guess the one exception would be in myeloma patients, there's some data for warfarin use.
Sure.
But even there, the guidelines don't recommend it because the aspirin data in that setting seems to be just as good as um, the warfarin data,
Yeah.
with maybe even less bleeding.
Is there any role for primary prophylaxis in palliative care patients that are getting ready to leave the hospital? The DOACs versus low molecular weight heparin agents, should it be continued?
That's a great question. I think that just boils down to sort of patient preference. There's good studies from Simon Noble in the UK, who takes care of palliative cancer patients, but is also interested in thrombosis. And he surveyed cancer patients, and once you explain to them what are sort of the symptoms of DVT and PERs, many patients chose to stay on anticoagulation.
Mm-hmm.
So I think that's really somewhere where I wouldn't mandate it because the goal of palliative care, of course, is patient comfort. But if a patient has symptoms from PE before and they're interested in preventing those symptoms again, because as you know, some of those symptoms can be really very, very bothersome to patients, then certainly I don't see any harm in continuing it.
Are you promoting routine screening for DVT in cancer patients? Is that what you're doing at Cleveland Clinic? There was a question from one of the audience on that.
We're doing it only in the high-risk patients, so score of 3 or higher, because that's about a 10% rate of DVT that we find. And we are seeing that it prevents hospital admissions and prevents emergency room visits. So we've continued that. So we published that data in January of this year, and I cited that in my slides. And we've continued it since that. So that was a pilot data, and we've continued doing it since then because the data seems so promising.
Terrific. What about the role of is there any role at all for dabigatran in cancer patients at all?
I have not seen any cancer-specific data, so I'm unaware of any. Do you know of any, Mike?
No. I mean, I haven't seen. I don't think they've even looked at their general population VTE studies. I don't think so. I haven't seen any specific cancer trials. That's for sure.
Yeah, I agree.
Question about patients with brain tumors or and thrombosis, or patients with severe thrombocytopenia. How do you treat those patients when they've developed a thrombotic event? Do you have changes in how you approach them?
Yeah, that's a really good question. So we don't, just taking sort of the brain tumor patients first. For the most part, and Jeff Zwicker has a really good cohort study, and I think published in Blood around this. For the most part, bleeding rates are not substantially increased with intracranial metastases. The two exceptions are renal cancer and melanoma. And even there, those types of tumors tend to bleed on their own, and it's not clear that there's sort of an excess bleed. It's just noted that there's more bleeding in those two types of cancers. So for patients with intracranial metastases, we don't alter our approach at all, and we would treat them just like we would treat somebody else, assuming that the brain mets are controlled with radiation, as most patients are. For primary brain tumors, I would not use low molecular weight heparin prophylaxis because in one study there was an excess rate of intracranial bleeding.
Right.
With DOACs, the data are very limited. We excluded primary brain tumors from CASSINI. AVERT, I think, allowed them, but there were only a really small number of patients that were included. So I don't think there's sufficient data to sort of say whether it's safe or not to use in that population. This is for prevention. For treatment, I think, be aware that there's an increased risk. Make sure the patient's informed, but there's also an increased risk of mortality from thrombosis. So you're sort of obligated to treat the thrombosis with anticoagulation.
I agree. I think maybe one more. There's been an overwhelming number of questions, so I think you've got the audience is very excited by this topic. What about patients with incidental thrombosis in cancer? Is it treated differently in cancer patients who have an incidental thrombosis versus non-cancer patients?
Yeah, I had a couple slides on that and I took it out because of time issues. But yeah, that is an important question. It's actually a very clinically meaningful question because in the U.S. especially, 40% of all PEs are diagnosed incidentally. So incidental refers to you send a patient for a CT scan of the chest because you're looking at their lung cancer, and then the radiologist calls you and says, "Hey, there's a PE." So that's an incidental diagnosis. That's those mostly are pulmonary emboli that are observed, but in GI cancer patients, which is my practice, we see a lot of superior mesenteric vein thrombus and renal vein thrombus. I think for PE the data are very clear. The natural history of incidental PE is almost identical to symptom detected PE. We don't even recommend using the term symptomatic or asymptomatic because incidental PE patients also have symptoms. It's just that the symptoms are attributed to the underlying cancer. So for incidental PE, I don't treat them any differently. For incidental visceral vein thrombi, so like the SMV thrombus, portal vein thrombus, it's very individualized. I see so many of these in my practice that if I were to treat every single one, 80% of my patients would be on anticoagulation, and that doesn't seem right. So I think I treat them if it's a new thrombus and if they're symptomatic. So if there's a new portal vein thrombus and the liver enzymes jumped up or they develop new, right upper quadrant pain or new ascites or something like that, then I would treat it. But the majority of visceral vein thrombi I tend not to treat because it's not clear that they have any meaningful implications. Most of them don't end up, obviously can't cause a pulmonary embolism. And some of them, in fact, are tumor thrombi, and they're not actually, venous thrombi. It's just the tumors invading into the portal vein, and it's causing a thrombus at the edge of the malignancy. So I don't think that would respond to anticoagulation.
Well, I'd love to take more questions. This has been an outstanding session, Alok. I apologize to the audience for not being able to get to all the questions. It's just there's huge audience response. And thank you all for tuning in. I'd like to thank Dr. Khorana for an extremely informative webinar presentation today. I'd also like to thank all of you for joining us and asking such great questions. Also like to thank colleagues at the National Blood Clot Alliance for hosting today's webinar. Very shortly, you'll receive an email asking you for your feedback on the webinar, so please respond if you have any comments you'd like to share. If you have additional questions about today's presentation, please contact Cynthia Sayers. As you can see, her email address on the slide, csayers@cdc.gov. Thank you all for attending. Thanks so much, Alok. It was a tremendous presentation.
Thank you, Mike.
Bye-bye.